Welcome to the Dental Implant Practices Podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, this is Philip Gordon. I'm the host of the Dental Implant Practices Podcast, and I'd like to invite you to a special event we're having. I will be hosting a free dental implant seminar, and the seminar will be September 14th and September 15th this year of 2018. It's going to be at Newport Beach, California, and the seminar is going to be called Dental Implant MBA. Come join me to learn all about how to get your Master's of Business in Implantology, learn everything there is to know about the business of implant dentistry, everything from marketing to consults to how to sign up big cases, how to get started with dental implants, everything from A to Z. I think we're going to have a great time. Friday, we're going to take a tour of two implant facilities, the Glidewell Hahn Implant Manufacturing Facility and the BioHorizons Implant Facility, their West Coast operation. We're going to have a lecture Saturday, September 15th, all day. We're going to have lots of guest lectures. We're going to have some big names come in. I can't tell you quite yet, but we're going to announce that soon. I'm going to be telling you all the secrets that I have to get all the implant cases, treat them successfully, and grow your practice, double, triple, quadruple your production, and how to kind of bulletproof your practice from recessions and DSOs and all those other things bombarding us every day. So come join me in Newport Beach this September 14th and 15th. You can register for the event on the Eventbrite website. Look for Dental Implant MBA Conference, or go to my new website, dentalimplantpractices.com. We have renovated our website to add some of the things that we're doing there. Or you can find the link on our Facebook group, Dental Implant Practices group on Facebook. Hope to see you there. Bye. Welcome back to another episode of the Dental Implant Practices Podcast. I'm your host, Philip Gordon. Today, it's a huge honor for me to introduce Dr. David Resnick. Dave, thanks for being on the show today.
Well, you're welcome. Thank you very much for giving me this opportunity to do this.
Now, you've got a very interesting pathway to get into dentistry, and you do quite a bit of things with implant dentistry and the AAID, so I know you've got a great story to tell. So I was going to have you do a little bit of introduction about kind of your early careers and how you got into dentistry, and then how you got into implant dentistry in specific. So I'll have you kind of pick up wherever you'd like to start off, okay?
That's fine. I did not graduate dental school till I was almost 38 years old. So I definitely have a different life before dentistry. Some of the different jobs that I had was, I cooked chicken at Kentucky Fried Chicken. Started at $1 an hour. That was back in high school. And then I ended up moving down to Madison, Wisconsin. I had been living in Superior, Wisconsin. That's where I went to high school. Moved down to Madison, Wisconsin. Did a lot of traveling. Took different jobs, different places in the country. And ended up working as a longliner for sword fishing in the Gulf of Mexico in 1976. We'd go out to sea for 21 days, come back for 4, or go out for 21, and that was
is that kind of like the show Greatest Catch or Dangerous? Remember that old show?
No, that's crab fishing. They had a show on TV for a while. I think it was called Life on the Line. It was about long line and sword fishing up northeast. This is Gulf of Mexico. But if you ever saw the movie The Perfect Storm, that's the life I led, except that we didn't die. Yeah, we managed to live through a lot. And let's see, then after that, I went back to school for a while to a technical school in Superior, Wisconsin, Indian Head Tech, and got a degree as a facility maintenance engineer and became a boiler operator. I enjoyed it a lot, and the problem was I had a night shift, and I would my job was just mainly watch the boilers. We had 3 large boilers, but we had tunnels running to different buildings on the it was an old had been an insane asylum back in the 20s. Then it had an insane asylum and the poorhouse and a TB sanitarium. By the time I got there, it was simply a warehouse for the indigent and for some adults whose families just couldn't handle them anymore. But at night, I'd go around and I'd cut pipe and thread pipe to fix all the different leaks we had in the tunnels where the steam lines ran. And then in the morning one day, the boss said, "Hey, Dave, you got to quit fixing that stuff." I said, "Why is that?" "Well, if you keep fixing it, we'll never get anything new around here." So I quit the next day. I thought, the hell with this. I want something to do. He didn't care if I slept next to the boiler all night long, but I wanted to do more than that. The irony is that whole facility has been torn down and is long gone. As a matter of fact, I happened to drive by it yesterday. So they didn't fix anything, and they also didn't get anything new. It's gone. Let's see. Then I went to school to be a surgical technologist at Western Wisconsin Technical Institute and became a certified surgical technologist and started working in the OR, I think back in 81 or 82, and scrubbed in on thousands of surgeries, all kinds, from craniotomies, amputations, bowel resections, oral surgeries, Leforts, jaw fractures, hip pinnings, total joints, just about everything, probably a few hundred C-sections, and enjoyed that quite a bit. That was really a very interesting job, needless to say.
Yeah. No, when you say ball resections, you mean joint?
Well, total joints. Yeah, we did total joints. Where we did joint replacements, hips, knees, rarely a shoulder, and actually a few temporomandibular joints. But there wasn't a lot happening with those replacements. There is more now. I believe they're custom making them because it's a unique joint. It's a difficult joint to replace. So I did that for a number of years, and then took a break from it for a while. Had a friend worked at a public health clinic, went as a dentist, went there, and that's where I really got exposed to dentistry. I thought, hey, this is pretty cool stuff. So I decided that I would go back to school and get the credits I needed in order to be eligible to apply for dental school. So I did that at a community college in the Minneapolis-St. Paul area, and then got into dental school in 1988. Continued to work in the operating room. I'd leave dental school at 5 p.m., and I would go to the OR, and sometimes they had some scheduled cases late afternoon, early evening. I'd scrub in on those, and then I'd take call all night long. And a lot of times there was nothing to do, but just many times we'd either have a C-section, a hip pinning, a bowel resection, who knows what it was. And so there were many nights when I was scrubbed in working all night long, but at 8 a.m. I was back there at dental school. I never missed a day, didn't skip a class, and did that for 4 years through dental school. I once checked, I was curious. On average, I spent 25 hours a week during dental school, actually right in the OR scrubbing in. I did that. I also worked for the railroad, Burlington Northern. I did that. I did construction. I'm trying to think what else. That's most of the jobs that I've done. So it is different. The typical dentist is afraid to take a scalpel and put it in their hand. But for me, I was very comfortable with that, which is probably why going into implantology didn't seem like such a big stretch for me. I had already been so involved with so many advanced surgeries that the implant surgery did not seem, too difficult to get involved with.
Yeah, once you've seen the inside of every part of a human body, reflecting a little tissue on the gums and putting in a thread and a jaw doesn't seem like a big deal, does it?
Well, it isn't for the most part. But, obviously, as you know and I know, we got a few very critical structures there we got to pay attention to that, if they're damaged, it could become a life-threatening or a life-altering ordeal for the patient. The irony of it is back when I graduated dental school in 92, started doing implants in January 93, and I had a patient that had come in who had congenitally missing, I think, first or second premolars. And the family asked me about it. I said, well, we can do some implants. And they had gone to a dentist in Fargo, North Dakota. He wanted to do 4 bridges and do 4 bridges with abutments that had teeth that never even had fillings on them. And I told the family, well, my gosh, there's no reason to be grinding down these 8 teeth to make 4 bridges and commit those teeth to crowns for the rest of this child's life. The kid was maybe 17, 16. They went back to the dentist in Fargo. Oh, he told them that implant surgery is very invasive, that they shouldn't do it. And they never came and did it. And I thought, God almighty. Now, fortunately, it's not that way anymore, but at that time, So he was going to go ahead and grind down 8 perfectly good teeth, remove all the enamel from them, and then put 4 bridges on. Now, if I'm not mistaken, that enamel doesn't grow back. I would have made an incision, drilled a hole in the bone, placed some implants in. The bone would have regenerated itself. The gingiva would have regenerated itself and healed. But yet, what he told them is what I was doing was invasive. And so, fortunately, in the 26 years that I've been doing this, I think now dentists would never tell a patient that that's more invasive, say, than doing a bridge. But at that time, there was still a lot of resistance to it.
Yeah, it's amazing how some people get that concept, and even to this day, some people don't. They just want to grind teeth. But
yeah, well, that's the way it is. That's because that's what they can do. But yeah, they got an obligation though to the patient to, if they don't do it, at least say, hey, listen, there's somebody you can go to that can do this for you. But this person was more predatory in their practice. They did not want to lose the patient. They didn't want to lose doing 4 bridges. Even though, in my opinion, I think most people these days would agree with me, that was not in that patient's, that young adult's best interest. There's no way that could have been.
So you got started in implantology pretty early. I mean, for being a general dentist, there weren't that many general dentists probably in the early 90s placing implants.
Well, I don't really know. I know that the real battles took place in the, so you can go way back to the 40s, 50s, 60s, 70s, and the dentists that were involved then, they were really ostracized. They're ostracized, they were turned into their boards for doing things that somebody said, they shouldn't be doing. And they really took the heat. I think by the time I came along in the 90s, there was a fair number of general dentists. You maybe had 4 or 5% of the population of dentists involved in implantology, but, figure there's 100,000 in the country at that time. There might have been 4,000 or 5,000 general dentists. I'd like to think now that most of the dentists, even if they aren't doing the surgery, they are doing the restorative end of it. And I don't know, maybe Phil, statistics. I have no idea how many general dentists are doing the surgery, but it's a lot more now, obviously, than it was back in 93. You think it's maybe 10 to 20% now or more?
Yeah, I would think 15 to 20% maybe now, and that's probably double or triple than what it was.
Oh, and then I think we could say probably 80 to 90% are doing some aspect of the restorative phases.
Yeah, I would think so.
Yeah, that's all changed. I mean, now it's an acceptable standard of treatment, and even the patients know it. Hell, I had patients who seemed to have accepted a lot more than the dentists that they had been seeing. Who were afraid to get involved for whatever reason.
It's definitely gotten mainstream, but I know back then it really wasn't. So how did you get involved with implant dentistry? Was it a certain academies? Was it a certain teacher? Was it a mentor? How did you get involved?
Well, I had a patient that needed an implant. That's what it was. He had an accident, lost his 2 front teeth, and I knew implants were the best alternative for him. And that's in the OR. There had been a few times when I assisted back in the hospital doing some implantology. I think at the same time we also harvested bone from the iliac because we were doing some other significant grafting procedures in the maxilla, probably Lafort's if I remember right. But at the same time, we did place some implants even, which looking back, that seemed pretty radical at the time. And so I had seen implants on, I think, 2 occasions, and I really had not at that time had any specific training, but I was reading everything I get my hands on, bought some textbooks, had journals, and then in 94, I believe it was, I had first heard Hilt Tatum speak in Chicago at a meeting and thought, wow, here's a guy I could learn from. He was talking about, I remember it clearly, it was posterior mandible, left side, how to do a tunnel grafting procedure with particulate. And I think the membrane at that time, gosh, I got to think what it was he was using. I can't think of the name. It was non-resorbable, but the, millipore. It was called millipore. He spent 20 minutes on that podium in his 1-hour lecture describing the incision. And what few lectures I'd ever heard before then, they just simply would say, oh, yeah, and you make an incision.
Mm-hmm, yeah.
But Hilt Tatum, to his credit, spent a lot of time describing the incision, where to make it, how to make the proper access. And I knew right then and there, well, this is a guy I want to learn from. So within a matter of months, I was down at his office. I also, at the same time, simultaneously had signed up for an AAID Maxi course at the Medical College of Georgia. And it would have been the seventh course that they had, seventh year they had done it. And so then I had a full 300 hours of continuing ed. I had gone to a few other weekend type courses previous to that. And so from there, it just kind of evolved. As I got more skills, I provided more procedures. I knew quickly that it was necessary to know how to graft the sinus because there's a huge demand for posterior maxillary work. People lose teeth there. But I also knew that, this is just the time when blades were not so much falling out of favor, but there was other alternative methods available, including sinus augmentation, which had been around for 10 years thanks to Hilt, even though it wasn't mainstream yet at that time. Yeah, I had placed a few blades, but I knew it was necessary to learn sinus grafting. So in early '94, I went and learned sinus augmentation. And so that's really where I started becoming, hopefully, what it was, a complete implantologist. I still maintain a general practice. I do general dentistry every day. I pull teeth. I do fillings. I do dentures, not always implant supported. It's true general dentistry.
Now you live and work up in rural Minnesota. So where are your offices? You've got 3 offices, is that right, between you and your wife?
We have 4 offices. Our main office is in Ada, Minnesota, which is ADA, not the American Dental Association, but Ada, Minnesota. Then we have 3 satellite offices, one in Fertile, Minnesota, one in Mahnomen, Minnesota, which is an Indian word for wild rice, Mahnomen, and then also in Twin Valley, Minnesota, which is near where we live. We're the only dentist in all 4 of those towns, and if you drew a circle around them or connected them with a line, there wouldn't be another dentist within that circle, and you'd have to go about 30 miles out past that circle, the outer edges of it, till you'd come to another dental office. So it's a sparsely populated area. We live in Norman County. Well, there's only 7,000 people living in all of Norman County. It's huge farms.
Yeah. So do you like the rural areas, I suppose? I mean, that's been your whole life. That's all you've known. Do you enjoy it?
Well, yeah, ever since I was about 18, I tried to live out in the woods as much as I could. And we're so fortunate, Debbie and I and our family, that we live in rural Minnesota. To me, it's the best quality of life I could have ever hoped for. It's peaceful. The people are wonderful. There's a good work ethic in our area. There's a high level of honesty in our area. There's privacy. We don't have any neighbors. They're a quarter mile away. And so being in the rural area and raising kids there and having a practice, is as good as it could possibly be for us. I got no desire to live in a big city. I don't think I could do it. I don't want to be around people that much, Phil. I like people, but not that much. So I want my privacy, and I get enough people at work, and after that, I don't want to hear somebody's car door or their dog barking.
Yeah. I like people, just not too many of them. That's just don't put too many in one place, That's great. Yeah. I really appreciate that. So you do any hunting or fishing up there, or any outdoorsman work?
Well, yeah, I'm not much of a hunter. Debbie used to do a lot of deer hunting. Once we started having children, she kind of gave that up. She used to bow hunt and rifle hunt. I've rifle hunted only a few times. I'd much rather go shoot a cow, because I like beef a lot more than deer. We go down on our folks' farm, and we're always eating everything but beef, and I kept thinking, why the hell can't we go out and shoot one of those cows? We've got to eat this deer meat and turtle meat and squirrel meat and everything else but beef. And so, of course, they were making a living with their cows, milking them. They didn't want to shoot one and eat it. But you don't have to be a hunter or a fisherman. We've done a lot of fishing over the years, but you don't have to do that to enjoy the outdoors and to live in the rural area. I mean, we have gardens. We have a couple different orchards. And so we're constantly outside doing stuff, whether it be sports with our kids who are now older. Got 3 boys. We got our oldest boy is Zephyr. He's 20 years old. He's entering his 3rd year of college. He's going to be a chemical engineer. And then we've got the next boy is Sunny Day. Sunny's going to be a senior in high school. And then the youngest guy who's going to be a junior in high school is Riley Rocket Tatum Roberts Resnick. And Zephyr pitched college ball for 2 years. He was a kicker for his college team for 1 year. My other 2 guys at our school, we have a very small school where we live in rural Minnesota. Their whole kindergarten through 12th is only a total of about 280 kids. So we got football, basketball, and baseball, the only 3 sports that we really have, and they participate in all that. You know, one of the other great things people should think about, you live in rural Minnesota and go to these small school systems. First of all, every teacher knows us. We know them by first name. They know us by first name. And kids get more opportunity to participate in sports, way more.
Yeah, there was 500 people in my graduating class, so if you wanted to play something, you had to be darn good at it.
Yeah, well, that's the way it is at a lot of schools. At our school, nobody tries out. You just get on the team.
Yeah. They're just trying to put a team together.
Well, that's it sometimes. I've been there where some of the younger grades, and they only had 4 kids, and they got a basketball game going for I think junior high. That's all that showed up that day, or that's all they could get. You know, that's what's nice about being in rural Minnesota, or rural anywhere. Doesn't have to be just Minnesota. And what dentists don't realize, there's just as much dentistry to do in rural Minnesota, rural South Dakota, rural America, as there is sitting in a big city. The services are still needed. And so you don't have to be in a big city to have a certain kind of practice.
Yeah, they're probably more likely to pay for them, too, because they probably get it.
Well, let's hope so. Anyway, they better.
So you got involved with the AAID through the Maxi course, and now you're pretty high up in the AAID. You're a Central District trustee.
I don't know if that's a high up, Phil, or low up. Some days it's hard to tell. You know, it depends what the issues are. But so I was a general member for a number of years, starting I think at the Maxi course I became a member. So that would have been in '95. I attended my first national meeting, I believe it was in either 1996 or 1997 in San Diego, and have not missed an AAID national meeting since. Somewhere around, I'm going to guess 12, 13 years ago, I became an officer for the Central District. It's more by default. You know, these are volunteer organizations, and it takes people willing to do stuff to make these things happen. And so I've been through all the chairs, so to speak, for the Central District, president. And then somewhere, maybe another 10 years ago or 15 years ago, I'm not certain when it was, I also became on the Admissions and Credential Committee. We're the committee that administers and are the examiners for the credentialing in the AAID. You can do 2 3-year terms with that. And so we administered the exams, the oral boards for the Associate Fellow and the Fellow in the AAID. I think in 1999, I became a Diplomate of the American Board of Oral Implantology. Yeah, at that time, I was the first one, the only one in Minnesota. I think there's about half a dozen of them now. And so, you know, I've been on the membership committee. I've been involved at different times in test construction, written test construction. And currently, I'm finishing my last of 2 terms as a trustee for the Central District. We'll be electing a new trustee at the national meeting upcoming here in Dallas in September. And maybe you want to run for it, Phil. You got nothing else to do.
No, I don't. No, I would. I don't think they'd take me at this point, but I keep sticking my face around. Eventually, they might. But yeah, I would. I'd love to do that.
Well, it's as I said. You know what? If people don't get involved, these organizations don't continue to exist. It's not enough just for people to pay dues and be a member. You got to do more than that if you want to see these things continue.
You do, yeah. And I'll tell you, they're great organizations because they provide so much for people that they don't understand. And a lot of people get into an organization and they just, like you said, they just pay the dues and they get the, they get the booklets and that's it. But if you really want the benefits, you've got to show up and you got to put the work in and be there and participate. And it's just like anything else in life. The more you put in, the more you get out. And
that's right.
I think, it's if people would be willing to do that, there'd be a lot there for them.
Well, the other thing I found with the AID, first of all, I've made some friends that I've had now for 20 plus years, 25 years, 24 years. And especially Jay Elliott comes to mind. He and we took the course together at the Maxi course. And between that and other people I've met along the way, especially through Hill Tatum, there's a lot of camaraderie and a lot of mentorship going on with AID members. And to me, that's been the greatest benefit of all, that I got people I could call. Hey, I got a question on something. What do you think? And, that's a wonderful thing to have that resource, that somebody who, either I respect and or trust, that I can ask them on a case or some technique, see what they think. And so the AID has always had a big emphasis on mentoring, sharing knowledge, helping others to advance their careers. I never, fortunately, maybe because I'm out here in a rural area and I don't have other dentists down the block from me, I don't feel like I'm competing, with the guy down the block. And so I've always been willing to help or teach anybody anything I think that I can help them with.
Yeah, and that's fantastic because, not everybody will do that. And like you said, it takes somebody that's got that attitude that, those are the people you want to stick to and learn from. And
I think the AID has more people like that than any other organization in dentistry. When I talk to other people, they're so busy competing with each other, the rat race, so to speak, trying to cut each other's throat to get a case. But I don't feel that the typical AID member is that way or has been that way. I hope that never changes.
There's enough missing teeth out there for us all.
Absolutely. Definitely.
There's no shortage of people missing teeth in this country.
We're just barely touching the tip of the iceberg, really, when it comes right down to it. The question is more, the limiting factor is what can people afford? That's what keeps them from doing things.
Absolutely, yeah. Now, you do a fair amount of teaching yourself. I know when I went out there with that week-long trip with Hill Tatum in France, you went along and, you got to do a little bit there. But I know you put on a big special event every other year. You do some block grafting courses. You teach for some AAID Maxi courses. Kind of tell me and my listeners what exactly you're doing teaching-wise, because I know it's a well-rounded assortment of things, and you've got some kind of subspecialties that you're known for and really do well at. So kind of share with people what teaching and lecturing you do.
Well, having the surgical background I have a really great foundation in surgical asepsis. And so one of the things I do teach, and it sometimes is part of another course or lecture I may be giving, but I do a lecture on how to set up an operatory to do a aseptic procedure. And I think that's something that's needed with the implantology, especially when you do sinus augmentations, deglove a mandible. These are pretty invasive procedures. And the mouth is a dirty place, but at the same time, I want to minimize the risk of infection for the patients. So I do teach asepsis. I also, as you said, I teach a course on block grafting. I do that a couple times a year. It's an all-day course. It's about a 4 to 5 hour didactic course. The learning objectives include when to graft, what are the options for grafting, and then how to block graft, because that's the option that this course concentrates on. There is some on particulate and membrane grafting in addition to it. And then Kilgore, if you're familiar with Kilgore models, if you remember from the typodonts, I worked with the owner there. We developed a model that I use for the block grafting that's got 2 congenitally missing teeth, number 7 with a horizontal defect, number 11 with a horizontal and vertical defect. In the course, I have the attendees do the number 7 site. There's skin on the model. You got to make an incision. You got to lay back the flap. You have to decorticate. You have to then shape the block and try it in, and then you have to, using a bone screw, make the block, attach it to the recipient site, and then cover it all with a pericardial membrane and sew it shut. And I'm very specific in how I want them to make the flap and each step of the way. It's almost like they're back in dental school because I have them come up and do a prep check at each step of the way. I'll show a video of me doing it with each step. Then we stop and they go ahead and do that step. Then they bring it to me and I give them some constructive criticism. And so that's what the course is. It takes about 7 hours. I'm giving it currently twice a year at the Rocky Mountain Tissue Bank in Aurora, which is a suburb of Denver, Colorado. The next one coming up is November 9th. And then also I teach that same course at 4 of the maxi courses currently, or 3 of them maybe it is. I got to think about this. The Oregon maxi course that Shane Sammy runs, I give it there. In Texas at the Tex-Max course that Jay Elliott runs, I do that there. And then I'm going to be doing it for the first time at the Howard University maxi course. This is their first year of it being put on by Bernie Dunson. And then also I'm going to give the same course at the Toronto maxi course up in Toronto this fall. But the other thing you mentioned, every other year I do a meeting here in Duluth, Minnesota, and it's open to anybody, although there's a limit to how many it can really accommodate. And it's been a great experience. Initially, it was just started out with my study club and limited it to about 25 people. But now I've opened it up to anybody who really has an interest in it and wants to come spend a weekend up in Duluth, Minnesota, right on the shore of Lake Superior. So we've had great lectures, 2.5 days of CE. And then we have a dinner. Last year, we rented the Glen Sheen Mansion, beautiful mansion. And people can Google this thing, Glen Sheen Mansion in Duluth, Minnesota. We had a catered dinner there. It was wonderful. Had a great time. We had everybody is welcome to bring their wives, their husbands, their significant others, their children. And then the Friday night, we have a dinner out at our house. My wife and I have a house on Lake Superior in Wisconsin, and we have everybody out. We had about 100 people here for the dinner last year. And it's an eclectic group. There's a wide variety of practitioners that are part of it. And so it's a great experience. Phil, I hope to see you here sometime for it.
Yeah, I'll be coming next year. I've already got it on my calendar.
Great.
So I'll be there.
Good.
For anybody who's interested, it's going to be the last weekend in July 2019. And this next one, we might combine it with the Alabama Implant Study Group. I'm just not certain if that will or won't happen. Traditionally, they're the first weekend in August. And matter of fact, I'm going to go there and give them the block graft lecture the first weekend in August coming up, so in about 4 weeks. And then I guess we're going to talk about trying to combine their meeting with my meeting for 1 year anyways, see what happens.
Now, what's the strength of the Alabama Study Group nowadays? Is it a pretty active group?
It's a very dedicated group, but the numbers aren't huge. I first attended one of their meetings. First one I went to was actually I think it was a subperiosteal course that they'd give at Root Lab. And it was a tremendous one-day course. Maybe it was a 2-day course because, they did the surgery one day and the next day they put the sub in. So it was a 2-day course.
That's just a couple blocks away from my office.
Yeah, great.
Right there in Leawood, Kansas.
Yeah, I don't think they're doing that anymore because obviously there isn't that much subperiosteal being done. And then I attended one of their regular meetings at Birmingham, Alabama. At that time, they had about 400 attendees. It was an excellent meeting, just a great meeting. But now I think they do a meeting twice a year, once in the winter, once in the summer, and they're getting somewhere between 40 and 100 attendees. I'm not certain how many they get.
Hey, that's pretty good.
Yeah, it's a very dedicated group of people that, and talk about camaraderie and mentorship. That group is really the most exemplary when it comes to that.
Well, that's enough to keep you busy. I mean, between that and 3 boys and 4 practices and a ranch and whatever else you got going on. I know you like to keep a lot going at once. A lot of balls in the air, juggling there, kind of like I do. But
well, even with all that, Phil, I still waste a lot of time watching TV. Believe it or not.
Hey, you got to squeeze in a little leisure, don't you?
Yeah, I can watch a lot of news, and some of these reality TV shows like the one you had mentioned earlier, what's the deadliest catch? I watched that, and I know how bad it is. That's a dangerous life, but it's fascinating watching that stuff. So, anyways, yeah, that's what keeps me busy. That's my life right now, and it's great. I'm so fortunate.
Yeah, we've got it better than most. I mean, you can't hardly complain. It's not worth it.
Listen, the dentist shouldn't be bitching about anything. They're making a good living. They're providing a wonderful service. They can support their families with comfort. And, I don't know how you feel about this, but really for Debbie and I both, one of our greatest things we're proud of is that we employ people. We have about 16, 17 employees, and, it's not easy employing one person, but to employ a bunch and give them a decent wage and hopefully make their lives better, I'm just as proud of that as the dentistry I provide.
Yeah, that can be the more challenging part of your practice, but it can also be the more rewarding part. They're almost like, I'm sure you feel like, you've got a dedication to them too, and help their upbringing, because these are people that, generally have limited, some of them never been to college, and some of them, the hygienists or whatever, they went through a trade type school like we did. That it's a responsibility and a joy and a challenge all in itself.
Yeah, well, it's kind of interesting because dentists, think that their job is to provide dentistry, and that's what it's all about, having an office. But really, one of their jobs, what I'd like to think, is to provide jobs. I've met a few dentists. They're so damn cheap. They don't want to employ anybody. They got one person at the desk who's supposed to assist also, right? I also met a dentist out of West Fargo. Guy doesn't have any employees. He doesn't want to have employees. Too much of a trouble. But you know what? If everybody did that, our economy would totally collapse. You got to be willing to hire people, pay them a good wage, and then if people are working, then we have an economy that works.
You'd be surprised how much further you get with a little help too. I mean, these people that try to do it all themselves, they're the ones that go crazy. And
if my assistants don't show up, I'm not showing up. They make me a better dentist. That's all there is to it. Whatever I think I'm capable of, I'm better when I have a good assistant. They make me a better dentist, and I think they would for any dentist. But gosh, I met some who can't stand having an assistant chairside.
Yeah, I won't even go in the room until my assistant's in there. I don't even know what I'm doing. I don't know where my stuff's at. I don't know where anything's at. I just sit there and talk to people until my assistants show up, and they're like, all right, now we'll get started.
That's right.
Now, you do a lot of IV sedation too, don't you?
Yes, I have been doing intravenous sedation since 1998. I got trained by Dan Becker, Dayton, Ohio, and so I've been doing that. We have a young associate, Alex Provo, and I just had him take Dan Becker's, what might be one of his final courses. Dan's trying to retire. But it looks like there's a fellow who may take it over and keep it going there in Dayton, Ohio. We'll see what happens. I think his name's Steve Scheffelberger. And Steve may go ahead and take it over. I hope so. And, I do a lot of implantology without sedation. I know other people who sedate every patient for implants. I leave it up to the patient. If I want to do bilateral sinuses, I'll encourage them to be sedated, but it's definitely not a requirement. If I'm going to do some significant bone expansion, and I use osteotomes and a mallet, I'm going to encourage them to be sedated. But other than that, there's really no implantology that can't be done without sedation.
Yeah, I do about 90% of it without, and then
I'd probably do more of it without.
Yeah, 95% even. And then I bring in an anesthesiologist for the stuff because I figure, boy, if we need this, it's going to get hairy. But I don't have the advanced training like you do in IV yet, and I don't know if I will or not. I've got a pretty good group. Being in a bigger city in Kansas City, I can hire that out pretty cheap. So, but I know you probably don't have that flexibility. So I mean that's another.
Well, it's not even an option where we are. But one of the good things about it, if you were comfortable with IV sedation and you were doing IVs, especially, I haven't had to send a patient, maybe only one person to the hospital for a really serious infection in the last 20 years because I'm comfortable putting an IV in, putting some IV antibiotics into the bag, and we sit them down and drip it into them and then tell them, listen, if the swelling isn't gotten better tomorrow, we're going to send you to the hospital. But in every case, that's worked. And so, but previous to that, I'd have been more inclined to send some of these patients to the hospital where they'd have been charged a fortune just to do the same thing I did to them, give them some IV antibiotics. But if you're not doing IVs, and I probably won't be doing them if you're not doing IV sedation, you're not going to be comfortable maybe starting IVs and then, hanging a bag and putting some antibiotics in. But it truly, is a lifesaver and saves the patient money in addition to that. People hate going to the hospital, especially for something like that. But
oh yeah.
So
well, and like you said, you can run things so much, antibiotics and steroids, and there's so many advantages. You can just drip things in and be all set there. I mean, you can all this, blood spinning. If you're into that, you can just draw that out. I mean, there's all kinds of reasons to have a good IV line going, but it's I haven't got the advanced training yet. I'm not sure if I want to concentrate on the putting somebody to sleep and putting a screw in their head. I've only got I've only got so many brain cells, so I got to spend them wisely.
Well, let me ask you this, Phil. So, with that in mind, now, do you do oral sedation at all?
Yeah, we do a little oral sedation.
All right, that's the most unsafe sedation in the world. You don't know what the absorption rate is on that individual. You don't know what their metabolic rate is. You can't titrate it. And then they're sitting there and you wonder, God, do I got to give them another pill? This first one maybe isn't working. You don't know what's going on with them. When you got an IV in, it's safe. You titrate it in and you're also ready to reverse anything.
Yeah, you're right on. I
don't even offer IV or oral sedation. Once I became IV trained, I quit offering it totally.
Yeah, I just do like a Valium or two, and then that's it. Or we do IV. I don't do much else.
Yeah, but you don't know when it's going to kick in. You don't know anything about it. I mean, it's an unsafe way to sedate people, in my opinion.
No, can't argue that.
Yeah, so get IV sedated, Phil.
All right, will do. Will do. See, that's why we have these calls. Now, what else do people need to know about what you're offering and what you're doing? I mean, I know you've got those courses and you've got a lot to offer, and you're active in the AAID. Is there anything else shaking up there that people need to know about you?
Well, the only other thing I'd like to emphasize to them is that as my practice has evolved, I've gotten more into site development, especially block grafting, and only with now using, and I'll name the brand, it's Rocky Mountain Tissue Bank block grafts that are vertebral in origin and irradiated. They're totally different than any other allogenic block out there. And I've done a number of histologies, had my own study going on this. I presented that to many people, and the results are just tremendous. I've concluded there's zero reason to harvest autologous anymore.
Now, I've tried explaining this to other people, and I've done some block grafting with Rocky Mountain Tissue Bank, and it's come out great. I've tried to explain this to other people why it's such a big deal, why their stuff's different, and I didn't have the answer. I just said, trust me, people smarter than me and more experienced than me know about this. Why is the vertebral and the radiated way that they treat theirs, and why is it so much better? I mean, some of these block grafts you get back, and it's just a piece of concrete, and it doesn't take well. And you've always heard bad things about, donor block grafts. Why is this so different, and why is it so predictable, and why is it such a big...
Well, first of all, there's different kinds of donor blocks, okay? So we'll talk about that. The typical donor block is from the ilium, maybe tricorticate or bicorticate. It's rock hard, and it's processed just like any other particulate you would buy from those other tissue banks. So it's hard to shape, and it's rock hard just like if you were to harvest autologous bone from, say, the symphysis or the ramus. And these blocks that are that hard, it's extremely difficult for the blood vessels that are coming into the site to penetrate into those blocks and revascularize them. And so even if you had autologous blocks, they're dead bone in a matter of hours because they don't get revascularized readily, and all the cells die anyways. So there's no advantage to it in that sense. The Rocky Mountain blocks, the way they're different, first of all, they're vertebral in origin. I think they're the only ones out there currently selling vertebral blocks. And if you think about your vertebra, they're like they're your shock absorber for your body. They're extremely cancellous with a very thin cortical layer on them. And they're compressible. And by them being compressible, they intimately adapt to the recipient site. Because they're extremely porous, you've seen them. They're like a sponge when you look at them. They're also like a sponge in how the blood that's there just soaks them immediately. So they'll intimately adapt to the site after you shape them and try them in, and then you fix them in with a bone screw. And they revascularize incredibly fast. And because of that, they remodel from the inside out, which is different than any other block out there, whether it be autologous or some other iliac block. Those all remodel through a creeping substitution at the interface between the recipient site and the block itself. And as you've seen them, when you uncover those other blocks, they still look like dead bone. And they are, because it's still the same cortical bone on the outside of them, and the bulk of it is still dead bone.
Yeah, they look like a wart growth that's...
Yeah, it's not good. But you uncover a Rocky Mountain block that's vertebral in origin and irradiated. When you uncover them, they look like the adjacent host bone. I've seen this over and over and over again with complete consistency. And so it works. It's when I first uncovered my first one using their blocks, pericardium membrane, human donor pericardium allograft. And first one I uncovered, I believe, was 2007 or 8. And I looked at it and said, man, this is like the best looking block graft, best looking bone graft I've ever done. What's different here? And then I started doing the histologies on them and learned more about it. And, I've never looked back, because I can't do a better graft procedure than I can in terms of results, what I'll get with that stuff. So, this may sound like a commercial, but this stuff works. There's a lot of other things that don't work nearly as well.
I'd rather talk about stuff that works than doesn't. It's...
Yeah, that's it exactly. Unfortunately, in the world of CE these days, there's a huge emphasis on being non-commercial on the podium. Oh my God, you're going to influence somebody and you're biased. But I really think all the people sitting in the audience, the attendees, they're intelligent enough to decide for themselves if the lecturer is biased, but maybe the material is still valid, and that they can then decide for themselves what they do or don't want to do with that lecture they just got, the material they were given. Is it something they want to use or not use? We don't need, unfortunately, the government and the boards and everybody else telling us what's a legitimate CE program. But man, right now that we're down that path, whether we like it or not.
Well, that's why I've turned down all those millions of dollars for speaking for companies, because that's the only reason I've turned that down. I don't want to be biased, no, but I just want to know what works. Honest to God. And that's it. And I just, tell me what works, and I want to hear from people who've got more experience than me. And if you've done 1,000 of these and 999 of them work, then who am I to come up with a better system?
Well, and the reality is, Phil, that it's okay in a lecture to be given anecdotal information. Not everything needs to be a university-based study to be valid.
Just tell me what works in your hands and show me how to do it. Maybe I can do it too.
Yeah.
It's important that it works in more than just my hands. Otherwise, it's not good enough, in my opinion. And you also don't have to be at a university to conduct a proper study or to do a study and to be scientific in how you evaluate what you do. Unfortunately, most dentists, in the heat of the moment and the battle and during the surgery, they don't want to do a biopsy of the bone. They just want to get in and get out and get their money and be done with it. All right, I understand that. But at the same time, there's a lot of missed opportunity to come up with some great information.
Yeah. Well, and I'm trying to transition to some of that too. Now that I'm past the point where I'm worrying about whether I'm going to make my next, overhead payment, my next, pay my staff and my bills. Now I'm kind of looking onto this stuff and kind of thinking, okay, let me dig deeper into this. I need to start doing some of this work myself.
Absolutely.
And, so I think you got to get to a certain point in your practice and your curiosity to, you got to know enough to be dangerous, but still have that curiosity spirit. And still kind of ask those questions. Well, why is this working? Why is that not? And then have something to put together. Now, you like pericardium. I've heard you talk about that. Why is the pericardium so much better?
Well, here's what I think. First of all, I believe it's a double cross-linked membrane. It's incredibly strong, piece of collagen, so to speak, that is, you can't tear it with your hands. Human pericardium is so strong. And the reason people die of pericarditis is that when that sac fills with fluid, the sac won't rupture, the pericardium. Instead, that fluid will compress the heart and it'll stop beating. You know, you got to get in there with a needle and do a pericardial centesis or that person will die. And then, of course, address the reason why they're getting the fluid, you know, for whatever reason. So it's incredibly strong, meaning you can sew to it. It's holds the suture well. You can't tear it. It has no memory to it. Once you wet it, it just drapes wherever you want it to be. It's incredibly thin. Pericardium is so thin when you wet it, you can almost see through it. And yet it has the strength of a non-resorbable membrane, maybe even more strength than some of the non-resorbables. So the advantages are, one, it's not space occupying, unlike a lot of other membranes. And that's a huge factor when you go to close. Because the more you got in there trying to close over, the more difficult it gets to get a good passive primary closure. So you have that advantage. It's slow resorbing. I've done soft tissue biopsies. I know how slow resorbing it is. You can have some slight exposures with it, and unlike, say, an alloderm or some other acellular dermal matrix, it doesn't turn funky. You know, it doesn't turn green and putrid. It will allow the soft tissues to slowly creep over it and to close. Now, I don't want an exposure, but if and when I've had them, it's never been a problem. So we got thin membrane, strong membrane, slow resorbing, cell occlusive. It's all the right things in the ideal membrane.
Perfect.
Yeah.
Yeah. Well, I mean, why mess with that? I mean, if it's doing everything you need, then stick with it.
Yes. Yeah.
Great.
You know, and since I'm on a podcast and I've got the opportunity, I'll give a plug for for Maxius Dental. It used to be called Community Tissue Services out of Dayton, Ohio. That's where I buy all the pericardium from. It's incredibly inexpensive. That's the other irony of it. And don't use it because it's cheap. Use it because you think it's the best stuff. But you get an equal-sized piece of any other resorbable or non-resorbable, you're going to pay more for it besides. And they're not as good a membranes.
Yeah, you'll pay about $160 for just a little stamp of resorbable membrane from somebody else. I don't know what Maxi's charging for that.
But it's not as good of a membrane.
Yeah, it's not.
That's the bottom line.
They're thick and bulky, and
well, there's no strength to them.
There's no strength. Yeah, it's like
they tend to resorb
cardboard.
quick. You don't want them exposed to get awful.
So anyway, so there's my pitch on pericardium. It's great stuff. Once I started using it and then seeing the end results, it's the only resorbable membrane I keep around the office. And there are still a few occasions when I use a non-resorbable where I can't get a closure on a case, not on a block grafting, but other things. Then I'll use a non-resorbable. Let it granulate in underneath the membrane, pluck the membrane out after 4 weeks, and let the tissues close. But that's pretty rare. I mean, it's once every few years that I find the need for that.
Okay, great. Yeah. That sounds awesome. Well, I think that's enough info for today. I've kept you for a while. I think we've got enough for people to figure out that you know what you're talking about, and you got some good courses to offer. I like your tips on the block grafting. I've done it a couple ways different. I've done a couple your ways, and I tell you, your way's a lot better. So that's how I'm sticking with it from now on. And I appreciate all that you're doing for the AID and for the Maxi courses. I just finished the Maxi course, and I know how important it is to have those programs in place. And like I said, just really appreciate all that you've done for myself and others out there, and look forward to maybe seeing you at, I guess you'll be at the meeting in September. So.
Hey, Phil, listen, thank you very much for giving me this opportunity. I think what you're doing is a great thing. And so thank you very much. I appreciate it.